Hi, it's Bram Duffee here for week 2 of our class where we're talking about patient participation. There are chapter 2. This is the lecture supplement to that work. And uh, when we talk about patient participation, we're looking at how involved the patient is in their healthcare decisions. And so there was a lot of emphasis back in the day, before you and I, on the physician being the supreme ruler. And as a supreme authority, they said what goes when it came to healthcare decisions. And let me give you kind of like an extreme example. I think that there was a time when a child might have been partially birth aborted by doctors in the moment during the baby delivery, when they realize that the child is deformed or the child is not normal. And so by terminating the pregnancy during the childbirth time, what that would do would be to make the decision up for the child, for the family, for the situation. And I'm not saying that kind of thing happened every day, but we're talking about healthcare before us, and we're talking about the kind of authority that was extreme that was exhibited by physicians of the time. And so those kinds of things were decisions that were made by the doctor in most cases. And so now you know that abortion is a big topic, and the reason I'm mentioning it now is because it shows the change that we've gone through in society and how we feel about healthcare, and it's now the decision that is being taken away from the doctor, right? Because I think a lot of it is that people understand these decisions. They have the capacity to understand, and maybe that just wasn't always the case before. And so that's why these decisions that were once in the hands of doctors were now put into the hands of mothers, are still controversial, and now they're being pulled back into the hands of the state, and the government's toiling with this issue. But all this to say that it's a great example of how in healthcare we have gone from the doctor being the supreme authority that would make these life or death decisions and be the designated person for that, to now we have a lot of shared decision making. And because there's this shared decision making, it means that healthcare providers just have to do a lot better job of explaining why it is somebody needs to do what they need to do. So you may have a patient that is supposed to get a procedure done, but they have a problem with the insurance, and because of the problem with the insurance, the patient doesn't get the procedure done right away, and then as a result they suffered a problem. And so if the patient would have been explained the importance of the procedure and told that if something is awry, call me back right away so we can troubleshoot any problems, or a pathway given to them just in case, then they might have been able to take that path. The VA hospital is famous for having a lot of scheduling problems. And so I have friends who are veterans, and so they might schedule an appointment, and then the appointment confirmation people call, and because the veteran doesn't answer the phone at the exact time that the appointment confirmation people call back, then they lose the appointment. It doesn't, and no notification happens that they lost the appointment. They just lost the appointment because they weren't there for the confirmation phone call. Or a physician has vacation time. They all of a sudden take the vacation time. No alert happens to the patient. just these scheduling frustrations can cause a patient to give up on the healthcare system. And giving up means a big deal. It means life expectancy is not as long. It means that they don't have as much to give back to society because they aren't here for it. So we have hiccups in healthcare that are causing people to give up. And we have to think about those, because it means that people are not able to get the mental health that they need, or even the medicine help that they need. Let me give you another example. There's a patient situation that I'm familiar with where a patient needed to be on a very high amount of blood thinner. They had been to the hospital, they'd been treated for a condition that required them to have a need for more of that high power blood thinner, right? And it was a blood thinner amount that was significant. So the patient goes to leaves the hospital, goes to their pharmacy right away and says, "Pharmacist, here's my prescription." And the pharmacist says, "Well, I need to double check this because this is such a high dose, I can't just give you this." And so they can't reach the doctor, and the patient misses out on the evening medicine, misses out on the morning medicine, because the doctor and the pharmacist are supposed to be talking about confirming this medicine. Meanwhile, the patient has now gone 2 doses missing their medicine and has had a stroke because they didn't have the blood thinner. And I know this is a real case. So communicating to the patient that if something happens that doesn't allow you to get this medicine, I need you to call this number. If something happens that prevents you from having this medicine, it could cause you to have a stroke. So we want to make sure at all costs you get this medicine. If there's anything that stops that from happening, this is what you do. See, it's these kinds of double checks that we have to give our patients, and not just leave them out to do their own thing. So when these kinds of road bumps happen for patients, sometimes they can be difficult to overcome. And it's one of the reasons why I like talking about this topic. It's one of the reasons why I like having this class, is so that we can look at what we're doing with our patients. One of the ways that patients commonly talk to health providers through just communicating, or for research use, or by asking questions, is through narratives. And it's like stories about the experience. And narratives are things that help us make sense about our experience. And there are different types of stories that people tell about what they go through in healthcare. And I want to talk about some of those. Restitution narratives are one of those types. And it's sort of like the embodiment and the belief that medicine can fix us. And so we can overcome health challenges and return to our previous lives. So it's like, I am hurt and I will get better and have my life back. And that person is able to talk about their story about how they survived a really bad car wreck where they broke bones, or where they're a cancer survivor and they went through that kind of intensity. So those kinds of stories are referred to as restitution narratives. And a lot of times we hear about these kinds of narratives when, in a motivational light. Another kind of narrative that we look at is called a quest narrative. And so a quest narrative is this idea that we are now in a new state of life. And, there's a journey that we're going through in life, and this is part of that. And so when we talk about a quest narrative, we're thinking about a person that's telling a story from a perspective of, this is what I am now. And having that acceptance of the problem and being able to, see that new normal as an opportunity for like personal growth or anything like that, despite of the health issue. So we could see the restitution narrative is, I'm going to power through this, and then the quest narrative is the person living with the chronic illness who finds meaning or purpose through their experience and is able to share that. So it's sort of a quest narrative. A chaos narrative is the third type to mention. A chaos narrative is something that is a story that's told by someone who's going through a crisis or right in the middle of their suffering. And unlike the restitution narrative or the quest narrative, which are like ones that have a clear beginning, middle, and end, this chaos narrative is really a full chaos thing. So there's a lack of ending. They represent a spiraling out of control situation with no for sure way to recover or get better. So these kinds of narratives are told by folks who have found themselves right in the middle of their crisis. And so these are the three types of narratives that you might find as you're doing your assignment this week that I wanted to mention. Not all patients want the same thing when it comes to their health care. And some patients prefer to maintain the uncertainty about their condition. Maybe that helps them avoid anxiety or, prevent information overload. If a person's diagnosed with that they're predisposed to something, then it might be something that they just don't want to think about too much. But a lot of patients also appreciate being involved in their healthcare decisions, right? And so while some prefer to leave those decisions to their family members, they might not want to stress other people about that. So there are all kinds of different ways that people look at healthcare and make decisions about how they're going to approach it and how they are going to see their situation unfold. And when it comes to healthcare, patients communicating with providers and patients being able to understand and do well when they're not right with the provider at the time, all this stuff can be challenging from time to time. And it's funny because it's one of the reasons why on the ambulance I take patients to the hospital from freestanding emergency rooms or doctor's offices sometimes. I mean, even though the patient can walk, the doctor is so afraid that they may not go because their potential detrimental decision about not going to the hospital could kill them. So they call the ambulance so that they have like a supervised kind of experience to make sure they make it to the hospital. So there are all kinds of different risks that have to be taken into account. But I think that if our patients understand what's going on, or the people that are taking care of them understand what's going on to a degree that they're able to prioritize the things that are important so that they don't have to lose out when the roadblocks come up out of their way, all those things are important. So I appreciate your feedback on the assignment this week so we can talk about what patients are saying and how they say it, and in that way be able to study this aspect of communication.